Hi, welcome to CR Arthritis at the Canadian Rheumatology Arthritis Association and Arthritis Health Professions Annual Scientific Meeting. My name is Eileen Davidson. I am a member of the Arthritis Research Canada Patient Advisory Board and a writer for Creaky Joints and Chronic Eileen. It is my pleasure to be here today interviewing Dr. Mary-Ann Fitzcharles, rheumatologist at McGill University in the Health Center Division of Rheumatology, and Alan Edwards in Pain Management Unit. Today, we'll be discussing her research in fibromyalgia and medical cannabis. Hi, Mary-Ann. Thank you for being here today.
Good evening, Eileen. It's a pleasure to be with you.
Well, let's start off first. Can you tell us a little bit about yourself and your role in rheumatology and how you got involved in it?
Well, I've been a rheumatologist for many, many years, and it's first of all, it's a wonderful profession to be in, and we have such wonderful patients. So I have patients that I've followed for 20 or 30 years, and it really becomes a family, doesn't it? So I'm also a pain medicine physician, and I straddle the two specialties. And perhaps the question is, how come? Why? And almost every single patient who has a rheumatic disease experiences pain. And we're very focused as rheumatologists to do the very best we can for the inflammatory rheumatic disease. We've got wonderful treatments for rheumatoid arthritis, ankylosing spondylitis. But in fact, many patients, even although their disease is very beautifully controlled, they still have ongoing persistent pain. And this has been the area that has been of great interest to me.
Could you tell us why patients may have a little bit of a pain, even though their disease might be well controlled?
Right. So what we really believe is that if you've had a peripheral pain stimulus, such as an inflamed joint, in some patients, for some reason, we don't really know why, the nerves become sensitized. And it's not only the nerves in the peripheral joints, but this sensitization moves up in the spinal cord and even up to the brain. And it's what we call a central sensitization. Now, we see pain in sort of in little silos. We see nociceptive pain, which is when there is a broken bone or an inflamed knee joint. We have neuropathic pain when we see a peripheral nerve injury. But we didn't really understand the pain that is just there without any real inflammatory process. And this brings us to the new understanding of a new third mechanism of pain, which we call nociplastic pain. And I believe that nociplastic pain, which is this pain sensitization of the nerves, is the underlying mechanism in the persistent pain that many of our patients have, who have well-controlled inflammatory disease, but have ongoing pain. The other condition that is really the prototype of nociplastic pain is fibromyalgia. And fibromyalgia, we believe today, is just a sensitization of the whole nervous system. It's as though the nervous system goes into overdrive and it just doesn't switch off. So without peripheral stimuli, there is still ongoing pain. So nociplastic pain is now being considered the third mechanism of pain. And the reason why I really like this definition is it takes away the stigmatization that many people had. Because many people would have pain and the doctor doesn't see anything, the family doesn't see anything, and people sort of begin to doubt what really is going on here. So nociplastic pain as the new third, it's not really a new pain, it's an understanding of pain which we cannot see, pain that we cannot identify by a blood test or even by finding something abnormal on an X-ray, but the acknowledgement that this is really pain.
Wow, that's actually really nice to hear. I know so many in the fibromyalgia community never feel actually heard because their pain is so invisible and hard to detect. Can you share any updates or recent updates that you've been working on in this field over the last year?
So certainly what we do know is that the understanding of nociplastic pain comes from the research world. We are still left with the art of medicine when we're sitting in the clinic and we have a patient in front of us or a person in front of us. So we unfortunately don't yet have a biomarker, which is a blood test or an X-ray, that can prove to an individual patient, this is what you have. But the research world has told us, has given us a much better understanding of these mechanisms. And clearly in the clinical setting, what we need to do is, first of all, recognize this, and number two, do the very best we can to treat nociplastic pain. And this will bring us into our treatments for pain. And to date, our treatments for pain are not very, very good, but there has been great interest in the use of cannabinoids. And at this meeting, there have been two lovely posters showing that patients with rheumatic diseases are exploring the use of cannabinoids, of medical cannabis. Many people are looking to medical cannabis for relief of pain, to help with their sleep, to help with anxiety. And in fact, one study was done in Manitoba, the other one was done in Ontario, and they've repeated what we did in Montreal, and we all are seeing the same information. We are finding the same evidence. So what we're seeing is that patients are looking to try cannabinoids. Almost 25% of patients with rheumatic diseases have tried cannabinoids or medical cannabis. Doesn't work for everyone. So probably about if 25% people have tried it, maybe 15% will continue to use. And this is becoming an area that is very interesting for us. Patients have easier access to cannabis because of recreational legalization in Canada, which makes life much easier. Very often our patients go and try cannabis on their own. The other area that is of interest is CBD. So again, I'm sure you've heard many people are trying CBD. Does it work? I'll tell you, unfortunately, we don't have very good evidence at this point regarding CBD. The studies that are currently underway are mostly looking at patients with epilepsy. They're looking at patients with important psychiatric disease. They're looking at CBD in the use of people who have addiction problems. And the range of dose that has been studied is very wide. But our patients with rheumatic diseases are really accessing fairly low doses of CBD. And I just want to give you one little bit of caution. If you are going to try CBD, then get it from a regulated grower. Don't get it from one of these cottage industries over the internet. And the reason is we don't know what's in that bottle. So if you have got it from a regulated grower, the content of the bottle, the content of the product in the bottle is much more reliable. And also there is much less likelihood of having contaminants.
What would you say for people who want to grow their own and make their own?
So again, there are legal requirements, and within every province, people must really go by what the regulations are within their province. I really don't have any personal experience of growing. I suppose you've got to be a very good gardener to get a good crop, but that certainly is quite acceptable for patients in Canada.
Mm-hmm. Have you heard of anything about how CBD works better if it's combined with THC?
So there is a lot of anecdotal suggestion that a little bit of both work together. but we really do not have the solid scientific evidence. So again, working and having worked as an academic physician, you really focus on the evidence-based medicine. We really don't want to use just anecdote, but the studies have not yet been done.
Does it work for people topically? Is there any evidence about CBD working topically for pain?
So that's very interesting. And I'll remind you that all cannabinoids are lipid products. They are lipid soluble. So they like a hand cream. So if you put hand cream on your hands, it stays in the skin. It doesn't get, your hand cream doesn't get down into your joints. Now, all the cannabinoid products are lipid products. So they're creamy products. And to get into the joints, they've actually got to have a carrier molecule that moves them down into the joints. Now, the products that are available, do they really have these carrier molecules? We honestly do not know. There was one study that was done in Australia on osteoarthritis of the knee, a very, very interesting study with very nice results. And they did have this carrier molecule. But unfortunately, this company is not going ahead with production of the product.
Oh, that's too bad.
If a patient uses an agent and uses it topically, and it's not too expensive, and they do say that they are feeling better, well, that's perfect. And I would much rather use a topical product than taking too much by mouth.
Mm-hmm. Are there any updates when it comes to CBD and pain management since last year or no?
I don't think so. Other than that, I think CBD is really taking off quite importantly.
Yes.
One of my colleagues in the States has just published a nice observational study looking at patients with fibromyalgia. It was an internet study, and Kevin Bernke, and an internet study. And again, something like 25% of patients with fibromyalgia have tried CBD.
Do you think it's only up to 25% because only 25% want to actually admit to using it because there's still some stigma behind using marijuana?
I don't think so. I think one of the major issues is cost. Cost
yes.
is really important. And, we've seen this in Montreal in our study of 1,000 rheumatology patients. Patients would often access the product initially by the legal medical route. And then, because it's costly, many patients have gone to the street, which is much cheaper.
Yes. All right, so moving on for our last few questions before I leave you go. Can you touch on the topic of the microbiome and how it relates in fibromyalgia and the important role of diet in health?
So this is now a really interesting topic. And so the microbiome is essentially, we've got bugs everywhere. We've got bugs on our skin and our mouths, but the microbiome that is of great interest is the gut microbiome. And we sort of think of the organisms in our gut as just being there, but they are actually very important. They're important to help digest the food, but they also are very intricately linked with our immune system. Now, there's been a lot of discussion about diet and how our diet has changed. And if you think from Neolithic times, when we were hunter-gatherers, and thereafter we started eating a little bit of meat, and then our diet changed to the Western diet, which is essentially a high-fat, high-sugar, low-fiber diet. And diet impacts the microbiome. So the organisms in our bowel actually respond to what we're eating. And you can change the microbiome, what we call diversity, by changing diet. Now, there are many patients with rheumatic diseases that say, every time I eat this product, or I eat too many tomatoes, I get a flare of my arthritis. And until now, we've not really understood what's happening, but it might well be that there are changes in the microbiome, which then affect the immunological system and cause maybe more pain. So we have done some studies looking at the microbiome in patients with fibromyalgia. And what we have identified is that there seems to be a certain patterning of the microbiome. So it's not that you have one bug or another bug, but it really is the balance of the bugs. And what we're looking at is we really want to have a good diversity of organisms in our bowel. And what we saw in our patients with fibromyalgia was that there seemed to be somewhat of an imbalance, that there were more of some of the bugs that we consider to be negative bugs or bad bugs, and a few less of the good bugs. And this brings us to look at why is there a change? Is there this change in the microbiome because that's just how the microbiome developed over years and years? Or has this been influenced by diet? And the answer is not clear at this time. But I think many patients are saying to us, what can I do about my diet? Is there anything I can do to improve my arthritis? Now it's very difficult to do dietary studies. Dietary intervention studies are really tough to do. But what simple advice can we give to everyone? First of all, a nice balanced diet is good. Lots of fruit, lots of vegetables. Cut down on the fat, cut down on the sugars, and increase the fiber. And there's a particular starch called resistant starch, which when this has been fed to little mice, particularly mice with lupus, they actually do much better. So resistant starch is what you get in everything that's brown. That's in legumes, lentils, chickpeas, potato skins, bananas that are a little greener. Resistant starch, you can cook your rice, put it in the fridge, and the starch in the rice changes from being an ordinary starch to a resistant starch. So resistance it means that it is only digested much lower down in the bowel. So rice, put it in the fridge, it changes it to resistant, and then you can warm it up and it still stays resistant. So
I never knew that.
Moving back to a much healthier diet, but we really don't yet have the evidence to tell our patients they've got to change diet. That going for a FODMAP diet or a low gluten diet, that's still too extreme for us at the moment.
Mm-hmm. I think it comes down to what works best for you and what your taste buds like best, that it's healthy. It's kind of finding your own personal treatment plan, and diet's definitely included in that. And it's all by trial and error usually. Yes.
Absolutely.
Now, last question. Do you have any final tips regarding a patient wanting to change their microbiome or get some medical cannabis? Do you have any last tips for them before I let you go?
So first of all, be open with your healthcare professionals. Be completely open, be honest, open, and have an open dialogue, because really this is shared healthcare. So if a patient or person wants to try cannabis, discuss it with your physician. And the physicians now are becoming much more understanding of the mechanisms of cannabinoids, much more cognizant of the harms as well as the benefits. So first of all, be open. Number two, do I have any magic suggestions regarding diet? I think all of these good healthcare practices are intuitive, but we need to be thinking about them constantly. So good physical activity, good regular meals, good sleep, keep the stress level down, and just remember, even 10 minutes a day of walking is very, very valuable for all of us.
Yes, I would definitely agree. I live all of that myself.
Wonderful.
Thank you so much for being here today and presenting with us. We appreciate all the work that you do.
Thank you so much, Eileen, and good night to you.